I would like to thank SAGES and the program chairs for inviting me to present in this session. I will discuss planning the perfect gastric bypass. Here are my disclosures, which are not relevant to this topic. First, when it comes to the perfect bypass, I am focusing on optimizing the procedure to have a low risk for early complications at the time of surgery and low risk of long-term postoperative issues for the patients. Specifically, I will touch upon patient selection, preoperative endoscopy, equipment and team considerations, as well as the role of preoperative low-caloric diet. In terms of patient selection, there are two separate concepts. One involves technical complexities. Technically difficult versus doable versus optimal are all different ways to describe the surgical environment, and I'll touch upon that in terms of how we can optimize the procedure. And then the second concept involves other predictors of long-term problems and how to best manage them prior to surgery. Patient selection is key as it pertains to technical complexities of gastric bypass. This is not to say that gastric bypass is not doable in specific individuals, but when it comes to optimizing the procedures, such details may matter. Patients with super high BMI can pose a significant challenge. Excessive visceral fat and short mesentery can limit the mobility of the small bowel, requiring intraoperative maneuvers in addition to the routine practice to decrease tension at the anastomosis. For these patients, I particularly insist on a more prolonged preoperative caloric diet, and we also discuss sleeve as a backup option at the time of surgery. Hostile abdomen can involve significant adhesions from multiple previous operations, or tethered small bowel due to previous mesh or a large abdominal wall hernia. All these can limit our ability to manipulate the small bowel enough to make an anastomosis, and two anastomoses in the case of a gastric bypass. Again, this highlights the difference between doable and optimal. Many times managing these adhesions is doable, but when it comes to optimizing the procedure, patient selection is where it comes into play. Patient selection further extends to identifying patients who will develop problems long-term following gastric bypass. This can be particularly the case for marginal ulcers. We have previously reported on the incidence of marginal ulcers in a large statewide population study of 35,075 patients who underwent gastric bypass, and they were followed over years. We found that patients with a history of smoking were 50% more likely to develop marginal ulcers over time, with an estimated rate of 17.8% at 8 years. Importantly, patients with a recent history of smoking who present for evaluation for bariatric surgery have a significant chance of, in fact, resuming smoking after surgery, even after an interval of smoking cessation prior to gastric bypass. This is a graph from a recently published study based on the lab's cohort, which found that at 7 years after gastric bypass, 61.7% of patients with a pre-surgery smoking history had in fact resumed smoking. So when it comes to optimizing gastric bypass, patients with smoking really present a challenge in terms of improving their long-term risks. Similarly, patients with chronic NSAID use or use of immunosuppressive therapy are also at higher risk for subsequent development of ulcers. However, oftentimes, especially for patients on NSAIDs, these can be modifiable risk factors and have less of an impact on long-term ulcer rate. Preoperative endoscopy can help us identify clinical entities that could change patient management. Specifically, patients may be found to have Barrett's esophagus or peptic ulcers or H. pylori. Additional findings can also be seen, such that could require resection at the time of surgery. Patients with duodenal adenomas would possibly need long-term surveillance and therefore may be best suited for sleeve gastrectomy instead. 3 to 10% of bariatric candidates will be diagnosed with Barrett's esophagus during their preoperative endoscopy. These should be enrolled in a surveillance program and importantly get endoscopic mapping of their disease. Hopefully and thankfully, it is a rare situation where patients with very high risk or premalignant lesions are identified, because these can pose a challenge in terms of proceeding with a gastric bypass, as it may limit further treatment options in the future. 4 to 20% of patients who are undergoing preoperative endoscopy prior to bariatric surgery will be diagnosed with H. pylori. Some studies have demonstrated a possible association between H. pylori and the future development of marginal ulcers, which is a potentially modifier risk factor. So when it comes to planning an optimal procedure, this information can be valuable because it will allow us to treat patients even prior to surgery. Peptic ulcers, and particularly gastric ulcers, are found less commonly than what I just mentioned, but still can be diagnosed in 2 to 5% of patients who are undergoing endoscopy prior to bariatric surgery. Missing this finding prior to gastric bypass may lead to patients having chronic abdominal pain or unclear etiology in the future, because it's very difficult to survey the remnant stomach. Also, a gastric ulcer may harbor malignancy, so many of these patients would benefit from subsequent follow-up endoscopy to ensure healing and verify the diagnosis prior to surgery. Now, the value of preoperative low caloric diet is been debated, but it has been shown to decrease liver volume, and visceral fat. One randomized study of almost 300 gastric bypass patients found improved self-perceived operative difficulty with a preoperative diet. So surgeons felt that the procedure was technically easier following a 2-week, 800-day calorie diet. Although there has been no significant evidence to document a reduction in intraoperative or postoperative complications with these diets, these rates are overall very low in bariatric patients. So moving that needle significantly is a daunting task. So when it comes to optimizing the procedure, and given the lack of downsides of the low preoperative caloric diet, I think it is a good step forward to make gastric bypass more optimal. Now, bariatric surgery is a team sport requiring a multidisciplinary approach to patient care. This extends into the operating room. So when it comes to planning the procedure, the elements of team and equipment have to be considered, particularly as this involves the performance of such procedures in possibly a new venue with limited institutional experience. In terms of the team, when there are new members in the operating room, discussing the steps and needs of gastric bypass prior to surgery can increase familiarity, decrease possible slowdowns during the procedure or other mishaps. Similarly, coming up with an unified approach to pain and nausea control prior to surgery is important. So discussing these issues with the anesthesiologist ahead of time can make the patient recovery smoother. If the assistant for the procedure is new or inexperienced, and as we're currently moving into July and August, we have residents in new roles, so this is a timely point. Sharing videos and going over procedural videos ahead of time can make the process smoother and more educational and beneficial for the trainee, the surgeon, and everyone in the operating room. Equipment needs for both routine flow as well as backup equipment for special situations should be discussed and addressed prior to surgery. This may involve the need for longer instruments or perhaps hemostatic agents that should be available at the time of surgery. To summarize, patient selection is key, and when it comes to optimization of gastric bypass, patient selection is really paramount in order to be able to have a procedure as we intend to have it and improve patient outcomes both at the time of surgery and long term. Preoperative endoscopy can change patient management and allow us to identify disease entities and findings that may need us to tailor our operation or even change the operation from a gastric bypass to something else, such as the sleeve gastrectomy. Making sure that the equipment and the team we need are available or everyone is familiarized with the procedure is important so that we can have a smooth procedure and good outcome for our patients. Finally, we mentioned how preoperative low caloric diet can improve surgery outcomes and make the operation somewhat easier. So although for many patients it may make no significant difference in terms of traditionally robust clinical outcomes, it may not decrease leak rates or bleeding rates, it can improve the liver size and therefore make the procedure easier. This is an approach that I take with all patients as it has very minimal to no downsides. Thank you for giving me the time, and thank you for involving me in this panel, and for any questions that you may have, feel free to email me.